Good evening, everyone. Welcome to our
Yeah.
speaker series tonight.
Welcome. Happy August, August 27th, Erin. Here we
I
are.
know, I
We're getting months
know.
already. Don't you love in our community? They're just the best. They lift us up.
Yes, I know, I know.
August
We love to have
27th.
you.
Oh my goodness.
I know.
I'm gonna
It's been
I'm gonna
flying by. I'm hanging on
yes,
to the last little bit of summer as long as I can.
agree. Agree. I feel like I'm going on strike and making September a part of the summer schedule. You know, can't we just roll that in to
Yes, yes.
the summer schedule? No,
Technically, we don't change seasons until the 21st of September anyway, and so we've got
yeah.
more summer to be had.
Exactly, exactly. Well, we have a great guest this evening. I'm very
Yeah.
excited to be your co-host this evening. I'm Sue Weldon, for those of you that don't know me, CEO and founder of Unite for Her. And I'm joined with Erin Pellegrin, who is our Senior Director of Culinary Nutrition and Education, no stranger to the Unite for Her community. And we always love bringing these experts in to talk about really important topics.
Yeah, and this is certainly a good one. We've touched on it before, but it never yields in the importance of this discussion. And I love that we're honing in on just one specific aspect of this. So tonight we will be joined by Dr. Meg Krasne, and we are talking all about pain management in palliative care. And palliative care encompasses so much, which we will hear about tonight, and pain management is approached from so many different angles. So hopefully this discussion will not only be informative, but bring new light to all that participating in, with your palliative care team, all that that brings to the table.
Yeah, and not to be concerned with the name, right? So many people get so worried about palliative care, thinking that that is a last hope type of approach, and it really is so important to institute it early on in your care. So I'm really grateful to be able to talk about the pain management and all the things that we can do. Like, why do we have to suffer in silence when we have such a great type of program in a lot of the
Mhm.
hospitals? Tonight is going to be featured Dana-Farber, but so many in the area have this type of program. I know none of
Absolutely.
this can be done without our sponsors, Erin. So if we can pop up that slide in the virtual education series, we do over 36 of these a year, and we bring on some of the best experts in the field to really enlighten our community. And we can't do it without their support. So for Unite for Our Connect, our presenting sponsors are West Merck and Novartis. We have support from our gold sponsors, Pfizer and Daiichi Sankyo, as well as our supporting sponsors, GSK and AbbVie. Just a wonderful collaborative approach. I know as a nonprofit, we can't do the work without our industry partners, without our hospital partners. And all together tonight, we're going to have all of us together to bring the best information on pain management and palliative care.
Absolutely. Thank you for that. And just a little housekeeping. So please remember to keep yourself on mute, but feel free to utilize that chat. There will be time at the end of our presentation tonight to have some dialogue and some Q&A before we wrap for our evening. So, and we are recording tonight's talk. So if you want to come back and re-listen or perhaps share this with someone that you think might find it informative as well, this will be available in our UFH Connect video library. And in that library are so many other topics. And although we are wrapping up tonight's month of events for August, we have so much to look forward to in September. So, just a little teaser of what you have to look forward to. So, of course, a lot of our events are around September, which is Ovarian Cancer Awareness Month. So, we will be honing in on that quite a bit, which we love to do for our ovarian community. But first, we have our virtual hangout kicking off September. That is next Wednesday, September 2nd at 6 p.m. And we are talking all about breast health and beauty with our adolescent population. So if you are parents, you have teenagers, nieces, nephews, neighbors, family, friends, and they have young girls, teenagers, this is a really important discussion. Everyone is welcome. We'll be joined by our beauty advisor, Jolene Hart, and Corinne Ellsworth Beaumont to talk all about that together. So that's next Wednesday, 6 p.m. Eastern. And then we have our speaker series. So we will be talking all about updates in ovarian cancer clinical trials. That is Thursday, September 10th at 6 p.m. Dr. Mark Shaheen will be joined by Dr. Leslie Randall, talking all about what is currently going on in the ovarian clinical clinical trial space, some new announcements, and what we can look forward to. We also have our Ask the Experts taking place on Friday, September 11th at 1 p.m. I'll be talking with Dr. Rachel Grisham of Dana-Farber as well, all about rare ovarian cancer. So really love to see that dialogue. We'll be streaming that live on our Facebook page. And then wrapping up the month of September, we have our second speaker series, Thursday, September 17th at 6 p.m. I'll be joined by Kieran Dillon of the Cancer Vaccine Institute, learning all about vaccines in both the breast and ovarian space and how they are being studied to both prevent and treat cancer. So really wonderful month to look forward to. And again, not only tonight's segment, all our past and upcoming segments, all available at uniteforher.org/UFH Connect.
You got it. Erin, I'll pop that in the chat as well so people know that they
Great.
can actually go there. And it's such an incredible, robust library. If there's a topic that you feel like you would love to see us cover, we are all ears. So go to uniteforher.org, or actually info@uniteforher.org, and tell us what you're thinking. But most likely, I'll tell you, Erin, we've been doing this for 7 years now, 6 years,
Yeah.
7 years.
Mhm.
We have a robust library. So always grateful to add new experts and sort of bring in the newest breakthroughs. I'm very excited about clinical trial conversation with Dr. Shaheen and Dr. Randall.
Yeah. Yeah,
Yeah.
absolutely. Wonderful.
All right,
So,
are we ready to bring on our
shall
guests?
we? I would love to. Yes, for sure. So, let's introduce Dr. Meg Krasne. Dr. Krasne is a palliative care physician at the Dana-Farber Cancer Institute and Brigham and Women's Hospital. She received her Doctor of Medicine and a Master of Public Health degrees from Harvard Medical School and T.H. Chan School of Public Health. She then completed the Harvard Interprofessional Palliative Care Fellowship Program and is now a member of the Dana-Farber Cancer Institute faculty. Clinically, she practices palliative care in both the inpatient and outpatient settings, and her research interest is all about ensuring patients and those in need, they have access to high quality palliative care. So please join us in welcoming our guest tonight, Dr. Meg Krasne.
Welcome, Dr. Krasny.
Thank you so much, Erin and Sue. I will just pull up my slides and let me know if you're able to see if everything's okay. Perfect.
Presenter view. Yep, perfect.
Oh, great. Well, good evening, everybody. Thank you so much for joining on this Thursday night. And thank you so much again to Erin and Sue and Unite for Her for having me. It's a real privilege to get to spend this time with you. My name is Meg Krasne. I'm a palliative care doctor at Dana-Farber. And today I really want to talk about two things. The first is what palliative care actually is, because my experience is that most people have it wrong. And then how we think about and treat pain that is experienced by people with cancer. So this talk is really built for people living with cancer and loved ones of those with cancer. And I hope you find this helpful. I'll be sure to leave a bunch of time at the end for questions so that we can have a dialogue. So just a quick, boring, but necessary slide. I don't have any financial relationships with companies that create any of the medications or products that we're going to talk about today. And everything I share is my own perspective, and it's not an official position of Dana-Farber or Harvard. So here is my roadmap for tonight. And at the end of our time together, I hope that you're able to walk away with three things. First is really an understanding of what palliative care actually is and how it can help someone with cancer at any point in their illness and not just at the end. Second, an understanding of why people with cancer develop pain in the first place, because the why really impacts how we can effectively treat it. And third, a working knowledge of the tools that we have to treat cancer-related pain, so that if you or if someone you love is dealing with pain, you know what questions to ask your providers and some of the general treatment options that exist. So let's get started. So part one, what is palliative care anyway? I love this slide because this describes how a lot of patients view palliative care when they first meet with me. I was in clinic today and I had several new patients who came in and said, what is palliative care? And I don't totally know why I'm here. Palliative care can feel like a black box. And some patients have never heard of palliative care. Others have heard of it passing, but don't know what it really means. And for others, there's an association with palliative care and end of life, which feels really scary. There's often reticence to open the box and understand more because of the worry of what might be found. So let's open it together. Here is the definition that I like best, and it's from the Center to Advance Palliative Care, or CAPC. It's one of our big organizations. Palliative care is specialized medical care for people living with serious illness. It focuses on relief from symptoms and stress, and the goal is improving quality of life for patients and their families. And I want to pull out a few words here because they matter really enormously. At any age and at any stage means that palliative care is not just for people at end of life. I see patients the week they're diagnosed, and I see patients years into their treatment. And secondly, alongside curative treatment is a really big one. Palliative care is not instead of your cancer treatment. It works right alongside it. You can be getting chemotherapy, radiation, surgery, whatever your oncology team recommends and you all agree to pursue, and still have the palliative care team supporting you at the exact same time. So what do we actually do? I think of our expertise in 3 different buckets. Bucket 1 is related to symptom management, and this includes helping to treat pain, nausea, fatigue, diarrhea, all the physical stuff that a serious illness and its treatment can cause. This is the bucket we'll spend most of the evening talking about, related to pain. Bucket 2 is coping with serious illness. This is about addressing the emotional, social, and even spiritual challenges that come with a cancer diagnosis for the patient and the people who love them. Fear, grief, family stress, the why me questions. We create a space where patients can talk about all of this stuff if and when they want. And bucket 3 is really around medical decision making. When there are complicated choices in front of a patient, such as different treatment paths with different trade-offs, we can help to navigate these decisions to ensure that the care that a patient gets aligns with what actually matters most to them. So, symptoms, coping, decisions, that's really palliative care in a nutshell. And notice that I keep saying we and not I. That's because palliative care is delivered by a team of physicians, nurses, nurse practitioners, social workers, chaplains, and pharmacists. Serious illness, like cancer, touches every part of a person's life, and so it takes a multidisciplinary team to provide the breadth of support that patients with serious illness need and deserve. Patients and family members may meet different team members depending on what they need on that day, but we all work together with the goal of helping patients live as well as they possibly can. Okay, now for the single most common misunderstanding I run into in clinic, at the hospital, at events like this, everywhere. Palliative care is not hospice. And I'll just say again, because it's genuinely the number one thing I spend time clarifying. Palliative care does not equal hospice. And here's really the way that I picture it. So palliative care is the big circle. It's appropriate at any stage of illness, and it works alongside any cancer-directed treatment a patient might be receiving. Hospice is a smaller circle inside that. It's a specific type of comfort-focused care for people who are no longer pursuing cancer-directed treatment and with a 6 months or less of life if the disease takes its natural course. So it's very specific. So every hospice patient is, in a sense, receiving palliative care, but the reverse is not true. The majority of palliative care patients are receiving active treatment for their cancer with the goal of long-term cancer control. Palliative care is an extra layer of support alongside the cancer care. And it's also important to say that when people are feeling more well, physically and emotionally, which is the goal of palliative care, people also tend to tolerate cancer-directed therapy better. So this is part of the reason why palliative care is viewed as a standard of care for patients with advanced cancers. So let's take a side-by-side look at palliative care versus hospice to summarize what we've been talking about. Palliative care is available at any stage of illness. Yes, it happens alongside cancer-directed treatment, and it happens mostly in the clinic and sometimes in the hospital. Once in a while, it can be provided at home as well. Hospice, on the other hand, is for patients who are not receiving cancer-directed treatment and have an estimated prognosis of 6 months or less. And around 90% of hospice care happens in the home, although it sometimes can happen at a facility or hospital, depending on the circumstances. So a major takeaway from this is that palliative care is a much broader service that is available earlier in the disease trajectory and is much more common than people think. Let me make this more concrete with 3 examples of the variety of types of patients I see in clinic and in the hospital. I changed some of the details, but these are typical patients like ones I saw in my clinic today. First is a 23-year-old woman with sarcoma of her knee on a clinical trial who's having a hard time coping emotionally with the reality of her diagnosis. This is a classic palliative care patient, nothing to do with end of life and everything to do with ongoing support. Next is a 64-year-old man with head and neck cancer getting surgery and radiation with the goal of cure, who has a bad throat pain from radiation. Palliative care helps to manage that pain so that he can get through his treatment. And last is a 72-year-old woman with metastatic cancer who's having trouble sitting down because of pain. We work on getting her comfortable enough to be able to live her life in a meaningful way. It's important to notice that these three cases span the spectrum of age and disease stage, and yet all have palliative care needs and would benefit from seeing our multidisciplinary team. So this picture, I think, also helps sort of click with how palliative care is used for patients. Along the bottom is time. On the left is from diagnosis, and moving towards the right is further along. Disease-directed therapy, the treatment aimed at the cancer itself, is the top orange layer, and it can be a big piece of care for a long time, sometimes for the rest of life. Palliative care runs the entire length of that timeline underneath it, from the moment of diagnosis. It can be a really small piece early on and a bigger piece later, if and when that's needed. Hospice, if it's ever relevant, is relevant after treatment aimed at the cancer has stopped. The point of this picture is that palliative care isn't a phase you enter later. It's meant to be there from day one, whether it's a small presence or a large one. And this is based on guidelines from the NCCN, or the National Comprehensive Cancer Network, a major oncologic governing body, which recommends considering palliative care from the time of diagnosis of a serious or advanced cancer and continued screening of patients for palliative care needs throughout the cancer trajectory. Okay, so moving on to the second part of our talk, let's discuss pain management. Pain is one of the most common, most feared, and most treatable symptoms in breast and ovarian cancer. Yet it remains underreported and undertreated. Patients do not always tell their oncologist how bad the pain is, and sometimes we do a really bad job of asking about symptoms to elicit that information. So I want to walk through pain using a patient story, and I'll call her Liz. It's not her real name, and some of the details are changed, but her experience is very true to life. And Liz is actually the third patient vignette I spoke of earlier, the 72-year-old woman with metastatic vulvar cancer having trouble sitting down because of pain. She was diagnosed in her late 60s with cancer that spread to other pelvic organs. She's a mother and a grandmother. She loves gardening. And by the time I saw her, she was having constant pain that was making it hard to sit on the couch, prompting her to lay down for most of the day and not to be able to engage in activities she loves. So I'm going to come back to Liz a few times today because her story is a great way to exemplify what we're talking about. The first question I always think about when encountering a cancer patient with pain is, what is causing the pain? It's so important because it has implications for the way we'll treat the pain. So walking through potential causes, the first is disease-related pain. That's pain from a primary tumor or from cancer that spread to other areas of the body, such as organs or the bone. And this is the bucket that Liz fell into, with pain at the site of her primary tumor and the disease in her pelvis. Another potential cause of pain can be treatment related. So things like chemotherapy causing nerve pain, which we call neuropathy. Hormone therapies can cause joint pain, and radiation can cause pain right where the radiation was targeted. Another example is surgical pain. So this is related to surgery itself, such as mastectomy, a lymph node removal, or a debulking surgery. Sometimes patients can have lingering nerve pain at the scar site even long after it's healed. And the last big bucket, which sometimes I think we think less about, is pain unrelated to the cancer and its treatment. This includes arthritis, an old back injury, or a sprained ankle. People with cancer are still just people, and they're subject to all of the aches and pains that everyone else experiences. Sometimes it's just ordinary, unrelated pain. And I will say that while pain from cancer and its treatment is our specialty in palliative care, pain unrelated to it is not fully in our wheelhouse, and we often defer treatment of that pain to other providers like primary care doctors or specialists like orthopedists, depending on what the pain is. After thinking about what might be causing the pain, we also think about a lot of other aspects of the pain. And this is a list of questions, and it's actually a mnemonic that every medical student has ever learned called OPQRST. And it is a list of questions that your provider is likely to ask you to understand your pain better. O is for onset. When did it start? P is for provocation and palliation. What makes it worse? What makes it better? Q is for quality. Is it sharp, achy, burning, throbbing? R is for region and radiation. Where is it? And does it travel anywhere? S is for severity. On a scale of 0 to 10, how bad is it? And T is for time. Is it constant or does it come and go? And one practical tip for any patient with cancer suffering with pain is to keep a simple pain diary for a few days before you go to an appointment. Just jot down the time, a 0 to 10 rating, what you were doing, anything that helped. It sounds simple, but it genuinely changes the quality of the conversation that you can have with your care team, because you're not trying to remember 3 weeks of pain from memory in a rushed visit. And this is one of the most important slides in this talk. And the idea of this came from a woman who essentially invented the modern hospice and palliative care movements in the United States. Her name is Dame Cicely Saunders. She coined the term total pain. And the idea is that pain isn't only a physical sensation. It has 4 dimensions, and they all feed into each other. Physical pain related to the pain one experiences in their body due to the effects of cancer and its treatment is very real. Psychological pain is related to anxiety, fears, and sadness, and also equally real. Social pain is pain related to strain on relationships, worry about family, finances, roles at home, and also equally real. And spiritual pain is pain related to meaning, purpose, and the existential questions that a serious illness can bring up, and also incredibly real. An individual's experience of pain is tied to all of those different domains, and it's not just what's physiologically happening in his or her body. Here's why this matters practically. If we only ever treat the physical piece with a pill and ignore that someone is terrified about what their pain means for their prognosis, or that they're lying awake worrying about who will take care of their kids, the physical pain often doesn't improve as much as it should. Good pain treatment needs to address all of the relevant aspects of one's pain experience. This brings me back to Liz. And when I first sat down with her in this room, actually, one of the first things she said to me was, "I think palliative care means I'm dying." And that fear was sitting right alongside her physical pain. And honestly, it was making the physical pain harder to treat. Once we talked through who we are and how it can be helpful, she was able to let her guard down and engage with treating her pain, which she'd been very suspicious of doing prior to that. She later told me she actually regretted not coming to see us sooner in her disease course. Liz's pain was constant, deep, achy pain. That was 7 out of 10 in severity, with some intermittent sharp shooting component, about 10 out of 10 in severity when it occurred. Her pain was worse with sitting and better with lying down, and it started several years prior to my meeting her and had progressively worsened over the preceding few months. Liz's pain, like most cancer pain, wasn't just one thing. It was physical, and it was also tangled up in her really real fear, and we had to treat both. Now let's get a little more specific, because different types of pain need different treatments. And this is a really key concept for us as well. So there are several big families of pain, and the first one is nociceptive pain. And that is what happens when your body's normal pain sensing system detects real tissue damage. And that comes in 2 different flavors. Nociceptive somatic pain is sharp and easy to point to, like a fracture, for example. And nociceptive visceral pain comes from the internal organs. So it's more of a pressure, cramping, or aching pain, and it's harder to pinpoint exactly where it's coming from. And this type of pain can happen in situations like a bowel obstruction, for example. The second big family of pain is neuropathic pain. And this pain occurs due to injury or irritation of a nerve or a nerve bundle, and it tends to feel like a burning, tingling, electric shock, or numbness, and it often travels, for example, down an arm or a leg. And this kind of pain you might get from chemotherapy-induced nerve damage or from a tumor pressing on a nerve, for example. There's also inflammatory pain, which occurs from things like cancer in the bone. And lastly, there's total pain, which, remember, we just sort of talked about a couple slides ago. It's when the physical, emotional, social, and spiritual are all woven together. And the reason this matters is that burning, electric, tingling pain often doesn't respond to the same medications as sharp mechanical pain. So figuring out which type really impacts what we use for treatment. So once we understand the type of pain, how do we actually treat it? I think of our toolbox as having 4 categories: non-pharmacologic approaches, topical medications, systemic medications, and interventional treatments like targeted procedures. And ultimately, we use all of these together to treat pain most effectively. So starting with non-pharmacologic interventions, the NCCN guidelines explain that for cancer-related pain, we should be considering these interventions alone as the first step for treating any type of cancer-related pain, or in conjunction with pharmacologic interventions as needed. They say that non-pharmacologic interventions can be particularly important for frail, older adults for whom tolerance of some of the pharmacologic interventions may be less. It's important to say that these listed modalities are evidence-based, meaning studies have been done showing their benefits outweigh their risks. Cognitive modalities include cognitive behavioral therapy, which can genuinely reduce how much pain interferes with one's life. There are things like relaxation therapy that can lower the body's stress response, which amplifies pain. And there are physical modalities, including work with physical therapists, body work, including massage and acupuncture. And there are bodies of data for all of these. For example, there's data showing that acupuncture is really one of the best treatments for chemotherapy-induced peripheral neuropathy. And so we often think about that for patients early on. And I know that these interventions are a huge emphasis of Unite for Her, which is incredible and so important. Moving to things that you put directly on the skin over the area that hurts. They come in several flavors. There are lidocaine patches, and this is one of the topicals I use most often. It works really well for pain that's focal, meaning localized in one specific spot, especially nerve pain. It has very few side effects for the rest of the body because it barely gets absorbed, which is one of its real benefits. There's capsaicin cream, and this comes from chili peppers. It can help with nerve pain from chemotherapy as well, although a warning is that it often burns for the first several uses before it starts to help. So patients need to be aware of that, or else they'll assume it's making it worse. There's also diclofenac gel. It's an anti-inflammatory gel It's good for things like arthritis or a sore joint, but it's not going to touch that deep pain. And then there are also compounded creams that your pharmacy can make with combinations of ingredients like lidocaine, low-dose ketamine, or gabapentin, which we sometimes turn to when standard options aren't quite enough. And that's definitely something to talk to your palliative care team about. They're well equipped to try and get you those compounded creams. I wanted to share with you the World Health Organization's pain ladder. And this is actually a really dated schema. It was created in the 1980s to think about escalating pain treatment. And the idea was starting at the bottom for mild pain and moving up the ladder with escalating treatments for increased pain. And now we look at this and see that it's actually a really flawed model. It's outdated way of thinking about pain because, as we said, the cause and type of pain is so important to thinking about how we best treat it. We're not so interested in escalating one's pain regimen as we are in finding the regimen that best suits them at that time. And things can change, which is why people continue to see palliative care providers over time, so we can continue to meet a patient's pain needs. So let's return to those pain types from a few slides ago, because it's really at the heart of good pain treatment. Sharp mechanical pain from something like a fracture is due to nociceptive somatic pain. So we use medications like Tylenol, anti-inflammatories, and opioids. Pressure type internal pain that's nociceptive visceral in nature, we use some of those same options, plus sometimes steroids. For nerve pain, which is the burning electric tingling pain, this is where opioids often don't work well. And so we lean on topicals and certain nerve-specific medications. And in some cases, specific opioids like methadone that have extra nerve pain benefit. For bone-related inflammatory pain, we use anti-inflammatories, steroids, opioids, and sometimes bone-strengthening medications or radiation aimed at the right spot. In total pain, it needs us to treat all of those contributing causes together and not just reach for a stronger dose of one thing. So I'll walk through a few of these medication categories in a little more detail. The first is the anti-inflammatories, like ibuprofen, which you may know as Advil or Motrin, naproxen or Aleve, and a few prescription versions like celecoxib and meloxicam. I want to be clear that these are different from Tylenol, which is confusing because I think we all bucket them together a lot of the time. Tylenol works on pain and fever, but it doesn't reduce inflammation. And anti-inflammatories are especially good for things like bone pain from cancer, other inflammatory pains, and pain that flares with movement. And some patients say to us, oh, I was told not to take NSAIDs, which yes, you absolutely may have been. And a few things we watch closely in cancer patients specifically is that these medications can affect platelets and they can increase bleeding risk. So we're cautious if your platelet counts are low from chemotherapy. They also can impact the kidneys, especially if you're dehydrated or you're on certain chemotherapies. And they can carry some stomach bleeding risk, which we can offset with a stomach protecting medication. And with long-term use, some of these have a small cardiovascular risk. And none of this is to say don't use them. It just means that we choose them thoughtfully, and it's worth checking with your team before taking over-the-counter medications, especially during active treatment. And also, when palliative care is starting medications like this, we often just touch base with the oncology team to make sure we're all on the same page about who's at risk for what. For nerve pain specifically, which is that burning, electric, tingling pain quality, we usually reach for a whole different category of medications. Common starting points include the gabapentinoids, which are gabapentin and pregabalin, or Lyrica. And they're effective and expensive, although we start at a lower dose and increase slowly, especially for older adults. Patients are often surprised when we recommend duloxetine or Cymbalta, as it's in a class of medications called antidepressants, but it actually has some of the best evidence specifically for chemotherapy-induced nerve pain. And it tends to be less sedating than gabapentin and pregabalin, so it's something that we reach for all the time and patients find to be really helpful. And then there's there are older antidepressants like amitriptyline that can help too, although we tend to use these less frequently because they can be quite sedating. And we just have medications that often work better. There's also good evidence, as I was talking about earlier, for non-medication approaches to nerve pain for chemotherapy. We talked about how acupuncture can be really helpful. We also know that exercise, both aerobic and strength-based, seems to help protect nerves during treatment. So lots of different ways to approach neuropathic pain. So I want to take a moment to talk about opioids and the stigma associated with them. And we've all seen the headlines about the opioid epidemic over the recent decades. And frequently, patients come into my office expressing fear around potential opioid addiction. And this is completely understandable, particularly because the opioid crisis has impacted so many of us, even on an individual level. And I do want you to hear from me that in the setting of cancer pain, used appropriately and under medical supervision, opioids are a legitimate, important, and often necessary tool. They are not a moral failing, and they are not a sign that things have gone wrong. What I actually see far more often in my clinic is the opposite problem of undertreatment. Patients who are so afraid of opioids or so afraid of being seen in a different light for taking opioids that they suffer in silence, rather than take a medication that could genuinely give them their life back. So used well, opioids generally help people function better. I have patients who suddenly are able to sleep and they're not waking up in pain anymore. They're able to eat more. They're able to move around. They're able to participate more fully in their lives. And we work to ensure that the medication regimen continues to meet those goals moving forward, making changes iteratively as needed, if and when the disease changes or the patient's body changes in whatever way. So let's talk about opioids practically. There are short-acting opioids like oxycodone, morphine, and hydromorphone or Dilaudid, which kick in relatively quickly and are used for pain right now as needed. And then there are long-acting opioids, like extended-release oxycodone or morphine, fentanyl patches, and methadone. And these provide steady, around-the-clock coverage for pain that's there most of the time. And side effects to know about for opioids, a really big one is constipation, which we always warn our patients about because this is the one side effect actually from opioids that does not improve over time. So we proactively treat it with a bowel regimen from day one and not after the fact. And other side effects include dizziness and drowsiness, which it can especially happen when starting or increasing a dose and usually improve after a few days as your body adjusts. But if you were to have any of those side effects with these medications, definitely talk to your doctor to make sure you're on the right dose. So when do we consider long-acting opioids? There are 3 signals that I look for. One is waking up in pain at night, even after taking your as-needed medication before bed. It's pain. Another is pain that's essentially constant throughout the day and not just occasional. And the third is needing your short-acting medication regularly, like multiple times a day, every day. And some patients even describe this phenomenon of clock watching, where they know they can take their medication every 4 hours and they're looking at the clock, waiting for the 4th hour to be up so they can take it again because they feel the pain returning. Any of these 3 is usually a sign that it's time to talk to your team about a longer acting option. So you're not chasing pain all day with the short acting doses and you can feel more comfortable. We also think about a few interventional procedures that can help with pain. One is palliative radiation, which is radiation aimed directly at a painful spot, like a metastasis to bone. It can be remarkably effective for pain, and I have had patients whose pain completely resolves to the point where they no longer take any medication for treatment of the pain. One thing to know is that sometimes the pain paradoxically actually gets worse for a week or 2 right after the radiation before it improves. So don't be surprised by that. You can work with your palliative care team to ensure that your pain is well managed during that time. Another intervention is nerve blocks. So these are injections aimed at specific nerve bundles in the body that are integral to the pain signaling pathway of specific cancer-related pain syndromes. A big example we think about a lot is a celiac plexus block for pancreatic cancer. As we know that the celiac plexus is a nerve bundle in the upper abdomen and contributes to abdominal pain for people who have pancreatic tumors. So often we have patients go and have these done and their pain is much improved without having to take any medication. So I want to leave you with this idea before we wrap up that just like your cancer treatment is tailored specifically to your cancer, your pain treatment needs to be tailored specifically to your pain, its cause, its types, and what matters most to you in terms of side effects and how you want to feel day to day. There is no single right answer for what works for everybody, and one's pain needs change over time. So it's our job in palliative care to be flexible and to make changes as needed to meet you where you are. So let's return to Liz. Once we understood what her pain actually was, which is nociceptive visceral and neuropathic pain in the setting of her locally advanced vulvar cancer, with additional emotional and social distress, we were able to build a plan together. We started a long-acting opioid, a fentanyl patch, and Lyrica, and she underwent a nerve block to try and block the nerves of her pelvis, which was very helpful for her. She told me that once her pain was under better control, she felt like herself again for the first time in months. And that to me is the whole point of everything that we've talked about today. So if you remember 4 things from today, I hope it is that palliative care is a multidisciplinary team providing an extra layer of support for people with serious illness and their families. It's available at any stage and any age, and it is not hospice, and it does not mean giving up on treatment. Treating cancer pain well starts with understanding why the pain is happening, its cause and its type, because that's what points us to the right treatment. Third is that opioids are a legitimate, helpful tool for cancer pain. Using them is not a failure, and with good palliative care support, the risk of addiction in this setting is really low. And lastly, if you think palliative care might help you or someone you love, ask your oncologist for a referral. You don't need to wait for things to get bad, and you don't need permission to ask. So I've included a few references here for anyone who wants to dig deeper into the evidence behind anything that I've shared. And thank you so much for having me. I'd love to hear any questions you all have.
It was fantastic, Dr. Krasne. Thank you. It's so good. I learned some new things as well. I didn't realize Erin knew about it because she talks to so many of our patients, but I didn't realize that you can do pain management, radiation for pain management. I don't know. I didn't know why I didn't know that, but that feels so freeing to me. Like it just feels like no medications, actually it can long last.
Yeah.
Absolutely. It's a great option for lots of our patients, and having radiation oncology involved is always a good idea, in my opinion.
Yeah. I love that. Well, we have a couple questions in the chat. I see some of us are coming off camera, which is great. Before we dive into those, just a question that I had, Dr. Krasne, and we will be sharing these slides with the recording. So to get those references and to go back and review, know that this will be available. But Sue and I were sort of messaging on the side, and I was saying I did in fact speak with one of our members today, and tomorrow she's going for some palliative radiation on some bone spots. So just out of curiosity, when a person is receiving radiation for pain management, what's the typical turnaround time before they might start to see some improvement? You mentioned perhaps in some instances it might get worse before it gets better. What's that typical timeline like?
Fantastic question, and it actually really depends on the type of radiation they're getting. So some patients will be seen by radiation oncology and they will say, let's do a single fraction, meaning a single dose of radiation that's higher dose, and that will be the whole intervention. Some people will say, let's actually do many doses of radiation over weeks, potentially. And sometimes they do sort of lower doses per day. I would say I have patients who, if they're getting a single dose, they'll say, oh my gosh, it's a few days later and I'm already feeling better. And there are some patients who will say, it's a few days later and I'm feeling worse. And there isn't really a great way to tell who's going to feel what. I will say in general, for the people who have longer radiation periods, they tend to get worse before they get better. But for some people, it's pretty quickly, I'm feeling better. And for others, there's a much sort of longer progression. For people who are feeling particularly, or whose pain is particularly spiking at the end of a long radiation period, they sometimes think about actually giving steroids just to help get through that period to decrease that inflammation.
Got it.
Yeah, great question, but everyone's just really different.
Yeah, wonderful. Thank you for that. And we're having some great comments in the chat, some great questions that are coming in. So to kick us off, first question that came in, what is the data and research on low dose naltrexone? And do you use this for your patients?
That is such a great question. Low-dose naltrexone is sort of a new pain intervention that people are thinking about. And it's actually not something we use regularly in palliative care. I think about it in general when I put my general medicine hat on. I really think about it for chronic pain syndromes in general. And I think it's becoming something that people are sort of considering, but it's not something that we really use much at all in our practice, I would say.
Okay.
There was another question asking, and we come across this a lot, palliative care centers just aren't at every hospital. So, many of her clients are at centers that don't have palliative care teams. What are your recommendations for those people to get this specialized care and pain management?
Such a great question. And this is one of my sort of interests is I want to make sure that palliative care is available to as many people as possible who need it. I would say, in general, sometimes in oncology groups, there are people who actually are also trained in palliative care. And so they're sort of a Trojan horse of a dual trained person in some of these institutions. And there are more and more oncology palliative care combined fellowships. And so I would look into that and see if there's anybody who's an oncologist who also has those skills and is able to provide those skills to their patients. I think that's one thing I would think about. Yeah. And I think using our voices to just sort of try and promote palliative care in general, it's really become a standard of care for oncology practice. And so my hope is that it will continue to grow and it will continue to sort of be available to people because the oncology guidelines are saying it should be.
Yeah. Krasne, is there a hub, is there a palliative care hub that people can go to or a website that has a lot of resources on there that they can at least start looking?
Absolutely. One that I find the most helpful actually is where the definition of palliative care I use comes from, the Center to Advance Palliative Care, or CAPC. They have amazing resources around palliative care. They have it for sort of provider facing and more patient facing. They have information for people who are trying to start palliative care programs. So if you're looking for information about palliative care and its implementation and its benefits, it's a really fantastic resource. And I can find that too, if that's helpful.
That would be, is it CAPSE?
It's CAPC.
CAPC. Got it.
Excellent. Okay, so we have another question, and certainly this comes up in a lot of conversations I have about peripheral neuropathy and the long-term side effects. And you mentioned that, approach for pain management, but certainly we know the numbness that can come along with it. So in treatment for if someone is just experiencing numbness alone, would duloxetine be helpful for that? And can you comment a little bit on the side effects for that particular treatment regimen?
Great question. Numbness from neuropathy is one of the most aggravating symptoms because we really have no medication that helps it. And duloxetine really just treats the tingling and discomfort and not the numbness, unfortunately. Related to neuropathy. So that remains one of our white whales where hopefully in the future we'll have better solutions to that. Yeah.
I do have a question, Dr. Krasne, relative to that topic. In the past, we've done a segment on cancer-related peripheral neuropathy, and we had an occupational therapist joining us, and she had mentioned some exercises. Could that be a route that someone could take to help with the numbness in particular?
I absolutely think occupational therapy for people who have numbness related to neuropathy is fantastic. I, in my experience, it's not that it actually necessarily improves the numbness, but it improves one's ability to function with the numbness. And that's such an integral part to all of this. So absolutely, I think occupational health is fantastic.
Great. Okay. Well, I'll pull that link to our segment as well and pop that in the chat to view.
Dr. Krasne, there's one, the whole time you were presenting, I was so curious where medical marijuana falls into the, types of treatments that you can use. I was so glad you talked about opioids because as you're talking about them, I have that fear, I need that education. I can imagine your patients feel that way. And then there's this whole stigma on medical marijuana too. So, but we've done many segments on medical marijuana. We've done it about palliative care. I'm curious on if your office or your practice uses it or recommends it. Legal in Massachusetts, right?
Yeah, absolutely. Absolutely. We do recommend it sometimes. And I would say, the pain data is not quite as good as some of the data for appetite. And so we sort of use it for specific things and nausea in particular. So we have a lot of patients who say, I take a gummy and it helps with my nausea and I feel more hungry. And so that's often sort of the use that we think about for it. We actually have a really great partner called ECS Wellness. It's actually a internal medicine provider who trained at MGH, who now has a sort of cannabis practice. And so we often utilize his services where patients will go to him and say, these are the specific symptoms I'm having. What strains do you recommend? In general, we know that indica and sativa are the two sort of big strains. Sativa is more activating, so that's often sort of appetite stimulating. And indica is sort of more of a downer, so for people who need help with sleep and things like that. So certainly it's something we think about. And honestly, there's some times where people are on clinical trials or for whatever reason, like it's a really integral part of our thought process. So yeah, absolutely something we think about.
Is that site ECS Wellness? Is it nationwide? Is it worth
They actually
putting
do
in?
virtual visits, I think, in all states, is my understanding.
Okay.
Yeah.
I know another one too. We actually work with Jefferson in Philadelphia, and remember Brooke and Greg, Aaron, that we did a couple medical marijuana speaking engagements on. So it's just good to be able to, you do talk to a physician, you do get
Yeah.
to sort of get a personalized plan so that they know exactly what they want to get, and then they can get it picked up or sent to them. So,
Exactly.
yeah.
Exactly.
All right. I'll pop that one in the chat too.
Wonderful.
Great.
And I will say
Great.
just something related that I was thinking about as we were talking is our center actually is doing a lot of research currently on psilocybin as treatment for mood, but also for
Yes.
pain.
I've talked to one of our members recently. I think she was trying to get into a clinical trial using psilocybin.
Yeah, there are a lot of trials going on currently here. And some of them have been related to mood. And now they're actually looking at pain, cancer-related pain in specific populations. So I think we're going to have more information about that in the coming months and years and what the effect of that is. And I think for
And
very specific patient populations, it can be really helpful. So
can you just share what that is,
yes,
psilocybin?
psilocybin is a hallucinogen. And so people often think of it as sort of a like party drug, I guess.
Yeah.
But
Mushrooms,
really
right?
it's, again, it's one of these meds where it's like misunderstood. There are lots of uses besides that, just as with opioids and all of these medications. But Johns Hopkins is one of the big centers that thinks about this. And now we have actually a few providers in the palliative care department who are doing research on this. So I think, yeah, it's really exciting.
Oh,
It's good.
yeah.
Dr.
Great
Krasne,
question.
very helpful. I know. I'm really enjoying the whole presentation. Your slides were so good, and we do a lot of these, but it was very approachable. And I know that type of just challenge that a lot of people have when going into palliative care. It hurts me to hear that one of the clients said that she was denied
Yeah.
for palliative care. And what were your recommendations to get, the specialized care and pain management if they're actually declined?
And I would wonder, I'm not sure what the location of that person is, but every sort of big academic medical center has a palliative care arm. And so even, often for these palliative care groups, we really take care of Dana-Farber oncology patients. So you need to have a Dana-Farber oncologist, but we also know who all the players are. And so it may even be worth reaching out to your local academic center and just saying hi, even calling as if you're making an appointment and just saying, I'm looking for a palliative care provider who's in this geographic area, and I'm just curious if anyone in your group knows of anybody. Often, I have fielded calls like that before, so I think that's absolutely worth doing. And even at some of these smaller institutions, even in the Boston area, out in these smaller towns, people have more and more palliative care access. So I imagine there may be something in your area that might work.
Yeah. So it's almost like try and dive deeper with the people that that they may know somebody.
Yeah, that's
Mhm.
right.
Yeah. This one was talking about doing aquatic type of, um, services, which we do with our passport, like at some of our Ys and ACAC, and we pay for that. So I was just curious
Wow.
Where you were from. But
Yeah.
Erin, did we get all the
We
questions?
have we have one other question that came in, which I love this question because it's sort of looking at it from a preventative perspective. So
Yeah.
preventative measures for reducing risk of chemo related neuropathy. So I love even that question because it's kind of posing the, can I work with palliative care to prevent the pain or prevent the side effect? What are your
Love that.
recommendations?
Yeah, absolutely. So there actually is data that if you start acupuncture, it can lead to lessened peripheral neuropathy. So that's something to think about. Also, I know that often in group settings, I actually just was with a larger group of oncology patients recently. There was discussion of the cooling hand and foot ice, which some of my patients absolutely swear by. I think there isn't amazing data to show that it's helpful, and also some people find it really helpful. So when I'm thinking about interventions, I always think, what's the burden and what's the benefit? And if we feel like that makes sense, even if the benefit isn't enormous, if the burden isn't so much and you can get it on Amazon for not too long and you aren't freaked out by having very cold feet, then it's something worth trying. We also sometimes for patients, I've had several patients who've had neuropathy with specific treatments, and then we're going to come back to that treatment again, and they're very worried about the neuropathy recurring. We've started medication for neuropathy. We've started a gabapentin or Lyrica preemptively at a low dose, and that's been helpful too. So I would think about all of those things.
Great.
Dr. Krasne, have you ever heard about fidget toys for neuropathy? I had a woman at one of our wellness days. Oh, it was so fascinating to me. She wants to start a business and she showed me what she bought. She ended up buying a whole bunch of different ones for her hands and feet, and they're fidget toys, and some of them are very prickly. And she showed me which ones she liked the best. But I felt like there was something there. I was so intrigued by this that these little fidget toys, like really the audience tonight could just they're not expensive. Go and try a couple different ones that you like, and you have different ones that you roll on your feet, and you have other ones that you have in your hands, and you put them in your pocket. And so she was working on a study. It was one of our patients. It was in Chicago, Erin, when we had our wellness day in Chicago, and one of our
Mhm.
patients came up and
I'll
showed
have to
me.
look into this.
I am intrigued. So
Me too.
yeah, yeah. Let me know what you find out.
Will do.
All right,
Wonderful.
very good. Yeah, so wonderful to have you. And Erin, another great segment. I think we learned so much, and very digestible. Well, I definitely have this on our website. You can go to the library so you can download it and just review the slides and really understand different ways that you can speak to your physician, especially if you don't have a palliative care center that is in your community. Dr. Krasne, thank you. We loved having you.
Thank you so much
Thank
for having
you.
me. This is such an incredible forum, and I'm so delighted that this exists. It makes it renews my faith.
Oh,
Good.
good, good. Well, we are delighted too. We are delighted too. We're delighted that we have such great support and we can find people like you who can
Yeah.
really make a difference in our community and what they can look to try and achieve with their pain management. So thank you.
Yep. Thank
Yeah.
you.
All right, Erin, that wraps up our August. Yeah,
Oh my gosh, I know, but that was like, what a way to go out. What a great,
really good.
super
She's
informative, super
better, right?
helpful, really thoughtful questions. This was just a
Mhm.
wonderful evening overall.
Yeah, yeah. If people wanted to learn more about palliative care, we've had a couple segments on this. This one is so thorough, so I think just rewatching this, I always like to hear things twice in,
Mhm.
for me when I'm learning, but you can go and get it in our library, but there are some other ones as well. So please feel free to do that. Jesse, I'm seeing that you're from Delaware, and I'm curious if you are on what side of Delaware, if you were near Wilmington, if you're in our passport program, because I was thinking about your aquatic and you could actually use your passport to get that paid for through a fitness membership. So, um, yeah, if you could just show Newcastle. Okay, gotcha. Okay, that is not an area that we have the aquatic, but
Yeah.
yeah, I would try some of the references that Dr. Krasny said in your local hospital and see if you can do some networking there who can make some of these available for you, some of
Mhm.
these professionals available for you for sure.
Yeah, I like that suggestion. I like the networking that the word you, and the way to view it. Yeah.
Yeah. All right. Well, a couple reminders, right, Aaron? So you want to rattle them off? We got four. We got
Oh my
four.
gosh. Yeah, we have a lot happening in September. Next Wednesday, kicking off, we're talking breast health and beauty with adolescents. So
Meh.
nieces, nephews, kids, family, neighbors, anyone that would be
No, I'm with you,
interested in
Janet.
having that
Don't take.
discussion. Next Wednesday,
I,
September 2nd, 6
I get you.
p.m.
Yeah.
Um, and and then we're jumping in for September Ovarian Cancer Awareness Month. So Thursday, September 10th, 6 p.m., we have our speaker series, Clinical Trial Conversations. Dr. Mark Shaheen and Dr. Leslie Randall will be joined talking about updates in ovarian cancer clinical trials. So really exciting. And they are two experts that just consistently work in that space. So we're really excited to dive in. Join us on Facebook Live for our Ask the Experts on the 11th at 1 p.m. I will be talking with Dr. Rachel Grisham of Dana-Farber all about rare ovarian cancers. So the different types, treatment methods. So we'll be diving into that conversation and then wrapping up September. We'll be there before we know it. Thursday, September 17th at 6 p.m. I will be joined by Kieran Dillon from the Cancer Vaccine Institute in Washington, talking all about vaccines to prevent and treat cancer. And we'll be specifically diving in and learning about the breast and ovarian space, among other research that they are doing. So please join us in September. It'll be a great month, but also come back and share this segment tonight. It'll be available at uniteforher.org/UFH Connect.
Perfect, Aaron. Wonderful. And again, of course, we want to thank our sponsors. We can't do what we do without them. We have quite a few that support us. So our presenting sponsors are West Merck and Novartis, our gold sponsors, Pfizer and Daiichi Sankyo, and supporting sponsors, GSK and AbbVie. They are such incredible patient advocates for us. We work with their teams that are in that area of support in the pharmaceutical industry, and they could not be more committed to putting the patient's voice, the patient's need forward, and they make an incredible partner. So we thank them.
Absolutely.
All
All right.
righty, it's a wrap.
That's a wrap. Wonderful. Thank you, everyone, for joining us and being with us tonight. Thanks again to Dr. Krasny. It was a wonderful evening. And hopefully, we will see you all again soon at a future segment.
In September. Yeah.
Yep.
All right. Good night, everybody. Thank
Good
you.
night, everyone. Thank you.